Yeah. Are you able to see my slides now?
Yes, sir.
Okay, okay. Fine, fine. So
Very
we
good.
have
Great.
how much time before we start?
Just 3 minutes, let's say.
Okay.
Professor Tariq Sharawi told me that he would like to join as well. So,
Oh, very good.
yeah. So I sent him a reminder. Let me see.
Okay.
Thank you for your time, because I know it's now late in India. It is 10:30. So, and
No
tomorrow
problem.
is a working day.
No problem.
Thank you.
You are based in which country?
I am in Dubai.
Okay, okay. So what is the time in Dubai right now?
It is 9
Oh,
p.m.
okay. So if the viewers are logged in, then should we start? I think you are muted.
Yes, sir. Let me introduce you, sir, first, and then we can start, because some of the audience will be with us here live, and some of them will be watching the YouTube streaming. We are streaming on YouTube at the same time.
Okay.
So, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody, and welcome to this very important session of the glaucoma series of Sinjab Academy Club. This time, our guest is Professor Tanuj Dada. We are very delighted and we are very honored that he has accepted the invitation and will give us some of his valuable time to teach us. Professor Tanuj Dada is currently Professor of Ophthalmology and Head of Glaucoma Services at RP Center for Ophthalmic Sciences, India Institute of Medical Sciences, AIMS, in New Delhi. Actually, he has over 300 research publications in peer-reviewed indexed journals and has authored 5 textbooks on glaucoma, including a text and atlas on gonioscopy. And he was very generous to share with us, as you saw, one of his very important books and video series, teaching series. Of course, he is a member and head of many societies all around the world, and his CV is full of, mashallah, achievements. So, I would like to say that he has innovated several new techniques of glaucoma surgery and pioneered the research on medication and glaucoma. So please join me. Welcome, Professor Tanuj Dada, and thank you very much. The stage is yours.
Thank you. Thank you very much for your kind invitation. And so today I'll be covering the basic aspects of the gold standard surgery that we do, that is trabeculectomy. And I have no financial disclosures. So you have to understand that why still trabeculectomy is known as the gold standard, because it has the best long-term IOP lowering as compared to any other form of glaucoma surgery. So it is still the gold standard for patients with moderate to advanced glaucoma. And the important point to consider is that this is one very unique surgery in which there is a paradox. The paradox is that you're trying to make a hole in the eye. And if you try to maintain the hole by using anti-fibrotics like mitomycin C, you can end up with hypotony and infection. On the other hand, if the body's healing mechanism has the upper hand, it closes the fistula and you end up with scarring and Bleb failure. So this is a very unique surgery when you are operating against Mother Nature. And that is why the critical issue is not only the surgical technique, but post-operative wound healing and early recognition and treatment of complications, especially caused by the use of mitomycin C. So the first question is that why are we still interested in trabeculectomy with all the modern new techniques of surgery? And that is because of its long-term outcomes. So supposing you diagnose a patient of glaucoma at the age of 40 to 50 or 60 years, you want a surgery that will last a lifetime. And that is only possible with trabeculectomy. This is one of the longest follow-ups of trabeculectomy, 20-year follow-up. And you can see 90% survival with topical medications at 20 years and 60% survival without medications at 20 years. So this is definitely a surgery that can give you a long-term control of IOP. And that is why we must become good at this surgery, especially for developing countries. So the previous study was trabeculectomy without anti-fibrotics. Now, if you see this second study, nearly 10 years of follow-up, a decade of follow-up, trabeculectomy with mitomycin C, 0.2 milligram per ml for 2 minutes. You can see 75% of patients could achieve IOP of less than 18 millimeters of mercury at 9 years of follow-up. That is a tremendous achievement to get such a long follow-up with a low IOP. And you can see the complications were very less, just 3% Bleb leak and 1.5% blebitis. And very important to see that the dose of mitomycin C is 0.2 milligram per ml. And that is very critical because that will reduce the infection rate. I'll come to this on a later slide. So we know now trabeculectomy is a surgery that can improve long-term outcome and provide IOP in the low teens. But the question for today's talk is that how can we improve the outcomes of trabeculectomy for our patients? So my residents often joke with me that whenever I start trabeculectomy, I ask them to pray to God, and I also tell the patient. And when you do trabeculectomy over the years, you realize that there is nothing in our hand. It is all in the hand of God, because how the body heals, no surgeon can decide. So always start with a prayer when you do a trabeculectomy surgery. And the other important caveat is to avoid high risk situations. So these are situations where trabeculectomy has high risk of failure. And the most important thing is to check the status of the conjunctiva. So a very simple thing is that you just press the upper lid on the conjunctiva up and down. And if the conjunctiva is mobile, that means it's a healthy conjunctiva and you can operate on trabeculectomy. On the other hand, if you find the conjunctiva is not mobile, then that patient is not a good patient to take up for trabeculectomy. This is a list taken from a wonderful book by Dr. Tariq Sharawi on the risk factors for trabeculectomy failure. And you can see, in addition to all kinds of secondary glaucomas, patients of diabetes, patients with conjunctival scarring, especially any form of blepharitis, meibomitis, nasolacrimal duct blockage, contact lens users, ocular surface problems, and use of subconjunctival anesthesia. These are all high risk factors for failure of trabeculectomy, and one must counsel the patient that there is going to be a high risk of failure if you are doing trabeculectomy in these conditions. A very important thing that I have seen many surgeons ignore is the use of pre-operative topical steroids before you do a trabeculectomy. Now, why is this important? Because most of our patients before they undergo trabeculectomy are on multiple topical glaucoma medications. All these medications lead to a subconjunctival inflammation. And if the conjunctiva is inflamed, that leads to post-operative fibrosis because the fibroblasts are already activated. So it is better always to reverse conjunctival inflammation by giving pre-operative fluorometholone 0.1% for 4 weeks. If this is not possible, at least give for 1 to 2 weeks prior to surgery to decrease conjunctival inflammation. And you can see that it will definitely enhance the success rate of trabeculectomy. The other common mistake that I often find being done in trabeculectomy is the use of superior rectus traction suture. So this is something you should avoid, because in this major trial from UK on nearly 1,500 trabeculectomies, they found that poor outcomes were associated with a superior rectus traction suture. And this is important to understand, because when you put a superior traction suture, you are injuring the muscle sheaths and you may trigger fibroblast proliferation onto the area of the bleb that can increase the risk of bleb failure. And additionally, why do you want your patients to have a complication of ptosis that was found in 12% of patients in one study? So avoid using the superior rectus traction suture. You can use a corneal traction suture, or you have special speculums available which infraduct the eye and you don't need any traction suture. The other important thing to understand is that never give subconjunctival injection of anesthesia or any subconjunctival drug in the area of the bleb. It can lead to bleb failure, and whenever you give an injection in the proposed area of the bleb, there might be a bleeding and then your entire surgery is going to fail. So never give any injection in the proposed area of the bleb. The most important point while doing trabeculectomy is that actually trabeculectomy is a misnomer. What you're doing is basically a keratectomy. You should always try to make a anterior ostium, because if the ostium is posterior and close to the scleral spur, there is a more tendency to get complications, especially like vitreous loss. Now, this is how you should do a trabeculectomy. There are various ways. I'm just showing one of the techniques. So the basic purpose is to make a fornix blaze flap and then use a crescent knife to make a 50% depth incision in the sclera. And then gradually seeing the crescent knife, you make a lambda scleral incision, cut both ends, and then you have exposed the scleral bed. Now here it is very important to see these three landmarks. You can see three different zones are visible here. This is the white zone, that is the sclera, and it will end here. This is the region of the scleral spur. Then you have this bluish transition zone, that is the area of the limbus, the trabecular meshwork. And then you have the clear cornea. For safety reasons, it is always better to make the entry into the clear cornea, and that will avoid any damage to the iris, ciliary body, zonules, and prevent vitreous loss. So after you have made a lambda scleral flap, you can inject the air bubble, and you always put a pre-placed suture before you make entry into the anterior chamber. In case the patient becomes uncooperative or has a coughing or there is a complication, or supposing you get an expulsive hemorrhage, then your pre-placed suture is already in place to close the wound. And sometimes after you make the ostium, you get hypotony and it becomes difficult to close the wound. So always put a pre-placed suture, and then you make full thickness entry into the anterior chamber. Very important to remember that you should leave 1 to 1.5 millimeter tissue on either side of your entry. This is a guard to prevent post-operative shallow chamber and will ensure a watertight closure. So I'm using an MVR knife to make an entry into the anterior chamber, and then you can just cut it open with Vanna scissor. So this is just one of the techniques. There are multiple techniques. Then you do a broad basal iridectomy and close the wound. So this is one of the techniques for doing a trabeculectomy. And what I showed you, that when you are making the ostium, this is of course congenital glaucoma, and when you are making the trabeculectomy ostium, at that point you can get a vitreous loss. So that is one of the complications of trabeculectomy. If you get a vitreous loss while making the ostium, so one of the point to remember is that always drop your traction. If you are applying traction suture, you must release the traction suture at the time of making the ostium, because when you apply pressure traction suture, the vitreous may bulge through the zonules, and then when you are doing the iridectomy or making the ostium, you can get vitreous collapse. So you should always have a vitrectomy machine ready in the operation theater, even when you are doing the trabeculectomy. And this is especially can happen in eyes which are ophthalmos with having congenital glaucoma. Additional points to improve outcomes are to use an anterior chamber maintainer, especially high-risk situations. Always use releasable or adjustable sutures. And if there's a high-risk one-eyed patient, then before you make the entry, you should put in some amount of viscoelastic like sodium iodonate, so that you do not get a collapse of the anterior chamber. This is especially relevant in eyes with Sturge-Weber syndrome or nanophthalmos, where you don't want to have a collapse of the anterior chamber because you might get a uveal effusion. This is a higher risk case with Sturge-Weber, and I'll just show you what is the difference here. So we are putting an anterior chamber maintainer. It will have a slight infusion, putting a pre-placed suture, and then making the entry into the anterior chamber. So there are two things that are going to happen. One is that the anterior chamber maintainer is going to maintain the anterior chamber through the entire surgery, so you don't get a shallow AC. And secondly, it is going to wash away any inflammatory mediators or blood that can ooze during the time of trabeculectomy. So doing this is a surgery being done under the AC maintainer. And then you close, and it can also be used to titrate the post-operative amount of aqueous that is flowing out. Now, one of the modifications that we recently published in the Journal of Glaucoma and advocate is to make a deep scleral pocket. So basically, you are trying to improve trabeculectomy outcomes by creating an intrascleral lake. And this is done by what we call as a trabeculectomy extra. So you have raised the laminar scleral flap, and then you make a limited deep sclerectomy. So here you can see this is the laminar scleral flap of a routine trabeculectomy. And then you make a deep sclerectomy, not going anterior onto the cornea or the trabecular meshworks. This is just within the sclera. The purpose is that this is going to harbor an aqueous lake, and that will prevent adhesion between these two flaps and augment the outcomes of trabeculectomy. Then you put in a pre-placed suture and then continue your rest of the trabeculectomy. So after you make the ostium, this is going to have aqueous within this deep gutter that we have created. So the basic purpose is to have a limited deep sclerectomy combined with trabeculectomy so that you have an aqueous lake that is maintained. And additionally, when you're deep enough, you're draining the aqueous three pathways: subconjunctival, intrascleral, and as well as through the choroid if you are deep enough. So that adds additional IOP lowering capability to trabeculectomy and also enhances the long-term outcome. A question often asked is, what should be the dose and duration of mitomycin C for trabeculectomy? So I would advocate that for a primary trabeculectomy, you can use 0.2 milligram per ml for 2 to 3 minutes. Whenever you're doing a resurgery or high risk situation, you can go 0.4 milligram. It's important that you use mitomycin C over a diffuse area posteriorly and never exceed more than 3 minutes. So the key is to have a broad application of mitomycin C. There are some studies that have shown that you may enhance outcome by combining subconjunctival with intrascleral mitomycin C. But when you are doing this, the total time should not exceed more than 3 minutes. So intrascleral means you have raised the laminar scleral flap, and under that you apply mitomycin C for 1 minute in addition to the subconjunctival use. There has been a controversy on whether we should use anti-VEGF agents such as bevacizumab or ranibizumab, but the answer is clearly no. There is no benefit of adding subconjunctival any of the anti-VEGF factors to trabeculectomy. There is no difference in outcomes as compared to TRAB with mitomycin C, and which will only enhance the cost of surgery. And you can see in this meta-analysis that the combination of bevacizumab did not add any benefit. So there is no point adding any of the anti-VEGF factors that are used by our retina colleagues to trabeculectomy, except for when you're dealing with neovascular glaucoma, where it is important requirement to reduce the ischemia before you do a trabeculectomy. Now, another common question that is asked is, should we use the Ologen implants? These are the biodegradable collagen implants as a replacement or adjuvant to mitomycin C. So in the last decade, there was a lot of use of the Ologen implants. But if you see the comparison of Ologen versus mitomycin C, you can see the outcome is quite bad with Ologen as compared to mitomycin C. 100% success with mitomycin C as compared to 50% with Ologen. So Ologen is not a replacement to mitomycin C. It has a much less poorer outcome. You can see in this European trial, this is the Kaplan-Meier curve of mitomycin C trabeculectomy, and this is the one with Ologen. And so this trial had to be stopped because of very poor success rate with use of Ologen alone. And they advocated that you combine Ologen with mitomycin C And this was our study comparing two groups, trabeculectomy with mitomycin C and trabeculectomy with mitomycin C. And in addition, we used an Ologen implant, and you can see no benefit, no difference in outcome. So after this study, we have stopped using the Ologen implant. We are no longer using it for trabeculectomy because the outcomes were not appropriate and it did not add any benefit. It just increased the cost of surgery. Another common question that I want to clarify is that should we do a trabeculectomy before or after lens extraction? That means if you get a patient with glaucoma and cataract, should you do a trabeculectomy and then do the phacoemulsification? Or should you do the phaco first and then do the trab? And as you can see that once you do phacoemulsification in a trabeculectomy eye, the bleb can fail. So cataract surgery can compromise the IOP control even when you are doing a temporal phacoemulsification with a superior bleb. And that is because of the release of the inflammatory cytokines that go into the bleb and shrink the bleb and cause bleb fibrosis. So remember that cataract surgery reduces the functioning of the filtering bleb due to upregulation of fibrogenic cytokines. So whenever you are planning surgery in a patient with cataract and glaucoma, you should first always do the phacoemulsification. This is another trial comparing the sequence trab first followed by phaco or phaco first followed by trab. And you can see that worse outcome is in the trab phaco group. So if you have to do a sequential surgery, always do the phacoemulsification first, and then subsequently, preferably after 6 months to 1 year, you should do the subsequent trabeculectomy. It is much easier to operate on a pseudophakic eye and you have a better outcome as compared to doing trabeculectomy first and then doing the phaco, because that can compromise bleb function. And even after you have done a good trab, as we discussed earlier, due to the inherent healing mechanisms of the human body, the bleb can fail at any time. So the important thing is that don't stop steroids very early. You should continue topical steroids for 8 to 12 weeks. And if you get a red sort of localization of the bleb, that means blood vessels are growing into the bleb, you should increase the dose of topical steroids and continue till the bleb becomes pale and ischemic. This is one of the techniques that we published in 2008. This is a slit lamp guided OCT, and we are doing a OCT guided needling of filtering bleb. So this is a new technique nowadays. OCT is in the microscope. So under the microscope, you can do this OCT guided bleb needling. This was, of course, a slit lamp based OCT system that we had. And whenever you do a needling of a filtering bleb, you should remember that it is not going to have a very nice outcome. Needling is mainly effective for an encysted bleb. Once you get a bleb failure with fibrosis, even if you do needling, you can see in this study, at the end of 3 years, 60% of patients had failed needling. So if you have failed needling, what is the other option? The other option is to do what is known as a posterior revision of filtering bleb. That means the bleb has failed. So instead of a fornix based flap, you make a limbus based flap. And then from the posterior side, you dissect and open up the previous existing serial flap. And this posterior revision showed much better outcome, producing an outcome of 95% at 1 year and 85% after 5 years. So posterior revision of blebs is a much better option for failed bleb as compared to the needling of the filtering blebs. And finally, whenever you are doing a trabeculectomy, there is a lifelong risk of bleb infections, and that you must counsel your patients that any time in the follow-up, they can get a bleb infection. And especially if any time a patient presents with a bleb leak, that requires urgent surgical repair. So these are the risk factors for Bleb infection, late Bleb leak, blepharitis, use of punctal plugs, and young patient with juvenile or pigmented glaucoma. These are the risk factors for Bleb related infections. And whenever you get a Bleb leak, immediately the patient requires some sort of surgical management. In patients who have a very early small Bleb leak post trabeculectomy, you can try oral doxycycline therapy along with pad bandage or a large diameter contact lens. This is we have found useful for patients of early Bleb leak. But once you get a late Bleb leak with folds in the retina, this is hypotony maculopathy, and this is the OCT showing the serrated look, thin cystic bleb with leakage that demands surgical repair. And many of these patients, when you check, you will get a CDL positive. You can see here the fluorescein getting diluted. So there is a leak present, and that is causing hypotony. So if you get such a situation, the only option is to do a Bleb repair. And this is a very simple technique, which is a Bleb sparing epithelial exchange. That means you just peel off the epithelium of the Bleb and overlay with conjunctiva. So I'm just showing a video of this technique. So this is a patient with a thin ischemic Bleb that we are staining with trypan blue that stains the dysfunctional epithelium. So you just scrape off the epithelium from the Bleb, and then you make an incision posteriorly around this area of the Bleb. And this is now the epithelium has been taken off. You make an incision around the Bleb and just pull the healthy conjunctiva onto the area of the Bleb and suture it with at the limbus. So this is a very simple technique where you don't require to disrupt the Bleb. Just take off the epithelium and then do a conjunctival advancement to cover the area of the Bleb, and that will take care of the Bleb leak, and that will restore the integrity of the Bleb and also reverse the hypotony maculopathy. This is a patient of juvenile glaucoma, and I'm showing a separate technique here. So there is a very thin ischemic Bleb causing hypotony maculopathy. So here, when we dissected the Bleb, in these cases, if you do prior imaging like anterior segment OCT or UBM, sometimes you will see there is a full thickness defect in the sclera. So in this situation, you have to plan to cover the area of the scleral defect. Now, in many places, the eye bank sclera is not available. So I'm showing a technique. This is known as the Momini's repair. So here, what you're doing is, this is the area of the scleral defect. You are raising a laminar scleral flap posterior to the area of the defect and then deflecting this flap anteriorly to cover the ostium. So now you can see the flap has been deflected anteriorly. So you raise a laminar scleral flap and deflect it anteriorly and suture it. So the area of the scleral necrosis is covered. And now, because there's a very large conjunctival defect, you can take a pedicle flap from the adjacent conjunctiva and rotate it onto the area of the defect. And now you can close the conjunctiva. So this is the laminar scleral flap put, and then a pedicle flap from the side onto the area of the graft and suture it with the conjunctival flap. If you try to do direct suturing of a large defect, you can pull on the LPS complex and cause ptosis in the postoperative period. You can see the preoperative thin ischemic Bleb, and this is after the conjunctival overlay with reinforcement of the scleral flap. So this is how you restore the integrity of the sclera and the conjunctiva in patients of late Bleb leaks. And this is very important to prevent infection and loss of vision due to hypotony maculopathy. So in conclusion, some take-home messages for you regarding trabeculectomy. You should always do a preoperative checklist, rule out the risk factors for failure and infection that must be ruled out. Try and give pre-operative topical steroids for 1 to 2 weeks prior to surgery. That will improve the outcomes by decreasing conjunctival inflammation. Never give any injection in the area of the bleb, and especially don't give subconjunctival anesthesia in the bleb area. That can lead to fibrosis, bleeding, and failure. Primary trabeculectomy, especially with a thin conjunctiva, use low dose mitomycin C. Don't exceed more than 0.2 milligram per ml for 2 to 3 minutes. This can be increased in patients who have risk factors of trabeculectomy has failed. Try to use a AC maintainer or a viscoelastic in patients who have got advanced glaucoma, high-risk situations, one-eyed patients, Sturge Weber or nanophthalmos. Always use releasable or adjustable sutures. One of the modifications that we have described, you can make a deep scleral pocket like a deep cystectomy that will harbor an aqueous lake to augment outflow. Use appropriate post-operative steroids for 2 to 3 months, and always have a lifetime surveillance for bleb leak and infection. If you detect anytime there's a bleb infection, after that has been treated or a bleb leak, you must do a surgical management of late bleb leak, either by a conjunctival advancement, or if there is scleral necrosis, you can apply a patch graft or a lamellar scleral graft like the one I showed you. So in conclusion, trabeculectomy is a high yield, high risk, and high maintenance surgery. So you should do your best and then pray for the rest. I thank you very much for your kind attention, and I'm happy to take if you have any questions. Thank you.
Thank you very much, Professor Tanuj Dada, for this very nice lecture. It's one of the most interesting lectures that I have ever attended. Although I am not a glaucoma specialist, but it's so easy to understand and it's direct to the point, very, let's say, very simple. Thank you, really. It's like a conclusion of the long years of your experience. And I'd like to welcome as well Professor Tariq Sharawi, who joined us. Professor Tariq, are you with us now?
Yes, I am. I am, Professor Mazen. Thank you very much. And thanks, Tanuj, for such an excellent lecture. I thoroughly enjoyed it. Thank you very much.
Thank you.
Thank you very much, both of you. So let's see if any of the audience have any question. Can we do cataract surgery with the trab at the same time? A good question, because I know that some surgeons are doing this.
Yes, definitely. When we have patients who cannot come for follow-up or they have an advanced cataract and also myopia, we do a combined surgery. But the long-term outcome of a combined surgery is much less than trabeculectomy alone. So definitely that is an option. But if the patient can come for follow-up, then the results are better with the sequential surgery.
Thank you, Prof. But do you think that this can be correlated as well with the stage of glaucoma? So, for example, if the glaucoma is advanced stage, it's better to do both at the same time, or maybe the opposite. So just I'm asking, what do you think?
So I think there are two, if you have a patient of angle closure, so primary angle closure glaucoma, we try to do cataract surgery alone because a lot of patient that opens the angle and lowers the IOP. And if for some reason the IOP lowering is not adequate, subsequently we add on a trabeculectomy. As far as primary open angle glaucoma is concerned and patient has advanced glaucoma and cataract, there we do a combined surgery because you want to deliver vision restoring surgery and you also want to lower IOP.
Now, is it related as well to the type of cataract? For example, if there is exfoliation, maybe doing cataract first and waiting some time, then the eye pressure will go down by time So can we say like this?
Yeah, so pseudo exfoliation, and these are higher risk eyes, and you require a lot of maneuvers to dilate the pupil, and you might get a post-operative more AC reaction. So in such cases, it is always better to separate out the glaucoma surgery from the cataract surgery. So trabeculectomy should not be combined, but now you have new techniques of minimally invasive glaucoma surgery of the when you operate on the canal of Schlemm. Those can be combined with phacoemulsification, not trabeculectomy.
Great, thank you. Another question, sorry. When do you apply mitomycin during the trab surgery?
So after you have made the conjunctival flap, you have dissected the flap away from the cornea, then you apply cautery to cauterize the vessel, and after that you apply mitomycin C before you make the scleral flap.
Great, and you mentioned there is another application as well in one of the modification that you did, that you do under the conjunctiva and under the flap as well when you do the lake.
If you have very high risk patient like post vitrectomy surgery, post keratoplasty or neovascular glaucoma, where there is very high risk of post-operative fibrosis. So only for those cases we apply 2 minutes under the conjunctiva and 1 minute after raising the laminar scleral flap, but not for routine cases because it can lead to problems and melting of the scleral flap late in the post-operative period. Only for high risk cases.
Fantastic. Professor Tariq, any?
Yeah, you know,
please.
Let me first say that Tanuj and I, we go a long way together. He is a brother to me and a very good friend and a scientist that I look up to very much. He has been instrumental on the global stage in glaucoma, in teaching generations of glaucoma surgeons worldwide, and I'm very happy and honored to have been able to collaborate with him on many aspects. We published actually books together, so Tanuj is and we see eye to eye on many things, but I still have some questions for Tanuj.
Yes,
coming from two angles, Tanuj. One is to brainstorm with you and reiterate some of the opinions that we share together. And the second is also to maybe clear the minds of people who are listening and people who are going to listen. You know, you have made it very clear that mitomycin should be used very wisely and in low doses. And as you might know, I am of the same school. I am very sparing with my mitomycin, and I use it with a lot of caution and respect to the eye. So having said all that, what do you think of the drive that is coming mainly, I would say, from Moorfields about using 0.5 milligram per milliliter for 5 minutes? I'm very wary because the 0.2 to 0.3 that we were using 20 years ago, you and I are handling a lot of bad blebs that resulted from that 10, 20 years down the line. So I don't know how we are treating those cases now, and still some authorities are advocating doubling the dose and almost doubling the application time, and perhaps waiting in 10 to 20 years from now for bigger catastrophes. So I wanted to know your take on that.
So Tariq, I think that is the reason why many of the studies like TVT study and all, you find that tubes are doing better than trabs. That is because the hypotony being reported with trabeculectomy, that is attributed to very high doses of mitomycin that they are using, 0.4 to 0.5 milligram for 4 to 5 minutes. So I will tell you my practical experience. So when I was a resident, my professors at that time used to operate 0.4 milligram mitomycin C for all the cases for 3 to 4 minutes. And now while I'm a professor at my place, all those cases are coming back to me for Bleb repair after a period of 15 to 25 years.
Yes.
So I am now having an epidemic of patients of hypotony, Bleb
Same
repair.
here, my friend. Same here, my friend. My clinic is full of them. Same here.
So now I cannot say anything to my senior professors at that time, but I totally asked my resident never to go beyond 0.2 milligram per ml because they are young and within their lifetime they will see this patient coming back to them. So I think that is a myth. This is like a time bomb, and you may be happy for 5 years, but after 10-15 years you may lead to loss of light perception of the eye, and I think that is doing more harm than benefit. If trabeculectomy fails, you can still salvage, but if you lose sight due to Bleb infection, I think then you are the one to blame.
Lovely. I have another question, Tanuj. I am doing many more deep sclerectomies than trabeculectomies. Still, I do trabeculectomies obviously every now and then, but I have never really taken on the habit of putting an anti-chamber maintainer. I'm always worried about the damage that is going to be caused to the endothelium because, the AC maintainer is really a bulky thing, and putting it, sticking it in the cornea, for a guy who does deep sclerectomies and doesn't open the anti-chamber at all, for me, it's kind of prohibitive. But I know that many authorities, you included, you like the anti-chamber maintainer. So for a guy like me who is not in love with anti-chamber maintainer, what can you tell me to really convince me to use them?
So I don't think, Tarek, that I realize that AC maintainer can definitely, it's a messy thing. And what I have switched to is for patients like Serge Weber, or if you have a 5-degree field, I put some amount of viscoelastic like Helon in the anterior chamber.
Yes.
And I find that a much better option because it lasts in the post-operative period for a few days, which are critical. So AC maintainer will only help maybe during surgery, but once that is over, the eye may collapse. So I want some tamponade even after surgery. So mostly I have shifted to using Helon for higher risk cases. And regarding non-penetrating glaucoma surgery, Tarek, I still feel that it is a surgery which has not still found its full potential because of the technical transfer has not been adequate. But I think it is definitely one of the surgeries which should be done more by the surgeons across the globe. It is a much safer surgery, gives good outcome, but I think the training is lacking for non-penetrating glaucoma surgery. That is why it has not picked up so much as it should have.
Yeah, thank you, Tanuj. I totally agree with what you're saying, and I totally feel as well that doing a trabeculectomy with viscoelastics is a very safe option, and I agree with it very much. Having said so, I have seen residents and fellows coming to me from different centers after having been half trained by other specialists. And those specialists and professors told them never to put viscoelastic in the antechamber because it will falsify your pressure control at the end of the surgery. They think that if you put viscoelastic, then when you are closing your flap, you are not able to gauge what kind of pressure you're getting. And I disagree. I think you and I, we agree that a good surgeon knows whether he has put a viscoelastic or not, what kind of flow he's going to get. And you see, you and I, we are from the same school of safety. At the end of the day, you need to make sure that the eye survives this trauma of surgery, that the patient doesn't lose vision, and any increase in pressure after the surgery is something that we can handle with the releasable sutures or suture lysis. Our main cancer of glaucoma surgery is hypotony. Yes. So I totally agree with what you're saying. I think what you gave today is a fantastic cookbook for anybody who wants to learn, how to do a really good trabeculectomy, which remains to this day one of the best options that we have. I mean, there's no doubt about it.
Thank you. Thank you, Tarek.
May I ask you, which type of viscoelastic do you use? Is it the dispersive or cohesive, or what is it?
So
Which
I
type?
use cohesive Helon 10 milligram per ml, just plain Helon, not Helon GB or Helon 5. That is my favorite. Not dispersive like Viscoat, because they can retain for a long time and cause rise in IOP. So I would use Helon.
Yeah, good. Great. Thank you both. Thank you, Tariq, as well for your input. I think there is a question as well from one of the audience. What is the preferred technique for anesthesia in TRAB? Is it subtenon a good one? If you want to do local, not general, Professor Tanuj, so where to inject the anesthesia? If we have to avoid the area where we are going to do the bleb, as you recommended, where we have to put it?
So there are three options. One is subtenon anesthesia. The other is that you do very posterior subconjunctival injection, very posterior, and then just gently massage the anesthesia anterior. And third is, if you have a cooperative patient, you just use topical anesthesia. So once you learn trabeculectomy, you can get away with topical anesthesia and always put a pre-placed suture. So nowadays, I have shifted a lot of patients to topical anesthesia, and first post-operative day, the eye is much better and the patient also feels quite comfortable.
Very interesting. So we can use the topical anesthesia that we usually use in phaco as well.
Same. Yes.
Although you are dissecting deep under the conjunctiva, you are cutting the sclera, all of that, it works.
So and when you dissect conjunctiva, and that time also before entry into the anterior chamber, you can put topical drops. So some of the patients, they are very cooperative, but you have to see the patient response on previous investigations, like during aplanation and other techniques, how he responds to touch. Some patients are very cooperative, and if patient not cooperative, then on the table, you can give additional anesthesia. You already cut the conjunctiva. So if the patient is not able to cooperate, you can give the subtenon at that time.
Yeah, thank you very much, Professor. I think those questions that we have so far. Really, thank you very much, Professor, for the very, very simple and nice lecture. I enjoyed a lot, and same the audience, of course. By the way, after we upload the session to the YouTube, maybe more than 1,500 audience will attend and see the videos again and again. So God bless you for all the science that you teach us. And thanks to Professor Tariq Sharawi for his time as well and for being with us. And thanks to everyone, and have a good night.
Thank you. Thank you very much.
Thank you, Tariq. Thank you.
Thank you, Tanuj. Bye-bye, Tanuj. Bye-bye. Bye-bye.